Good evening, everyone. Thanks for joining us at 7 p.m. on a Wednesday, East Coast time. Jesse McClaren and I are super excited to be here. I'll start with Jesse. Jesse's a good friend and colleague. We both work at the University Health Network in Toronto. Jesse's an assistant professor, and he is a master of ECGs, and I'm super excited he's going to be here with us tonight. I'm David Carr, also work at UHN. Love to be here with CAEP. Love to be here on Wednesday evening. Before we start our STEMI-ish talk, and the way it's going to work is Jesse and I are going to give a talk. I'm going to speak first. Then there's going to be a break. Jesse's going to come. And then afterwards, we're going to leave about 10 minutes for questions. But before we start, a little bit of a breather. We're just going to go to a short video from Ian Steele from CGEM, just to kind of get a sense of how high quality this journal is and looking forward to things to come. So why don't we take it away with a short video, and then we'll come on live for STEMI-ish.
Hey everybody, this is Ian Steele, Editor-in-Chief of the Canadian Journal of Emergency Medicine, and I'm here today to tell you about a feature that is specifically for frontline emergency department clinicians and is very cool. We know that the major journals like New England and The Lancet publish the big practice-changing studies, so we introduce our Need to Know Journal Club series, page-and-a-half structured reviews by Canadian academic sites. This is an example from the January CGEM issue published last week. Congrats to Doctors Reagan and Lynn from the University of Calgary. Need to Know rates the articles on the methods and the usefulness to you, telling you instantly whether you should even read the rest of the piece. Methods, usefulness. Our reviewers perform a formal critical appraisal and summarize the strengths and the weaknesses of the article. Best of all, they give you a simple bottom line on what you need to know. Very helpful for clinicians. By the way, I'll give a big Twitter shout out to anyone who can name the artist singing my background music. You'll be surprised. Please check out the January issue of CGEM. Bye-bye.
Who's ready to talk STEMI-ish? There's an ish here. And what we're going to do today is go over the ish, go over the STEMI. Two separate talks. Here we start. One thing that's important, just a bit of housekeeping to know, is neither Dr. McClaren or I have any financial disclosures or anything to suggest any conflicts. So let's move on. Now, 3 times in this talk, I am going to ask your audience your opinions. Now, I don't have the special ways to look at you in the audience, but what I'm going to do 3 times is I'm going to count to 3 and ask you to shout things out. And it's only 3 times, and believe it or not, I can actually hear you. So the first question, the first part of this talk is I'm going to count to 3. And on the count of 3, you're going to tell me how you'd manage this patient at your shop, because this is across Canada. Okay? Everyone, put down your drinks, your food. 1, 2, 3. I heard some TPA. I heard some cath labs, but I got to tell you something. We don't manage EKGs. We manage patients. And that's a very important thing. Now, cardiology is a biomarker, whether it's high sensitivity or not, that helps. EKGs help, but I'm no expert at ECGs, and I'm going to leave the expert EKG interpretation to Jess. But what I'm good at is this. Now, I have a bit of a disclaimer. I'm actually not that great at POCUS. I have pretty average skills. I routinely lie about the JVP and the fundus. And hey, during COVID, I barely examined people, but I take a good history. And as Dylan would say, what I want you to realize is, how does it feel? And I think it's important when we walk out of this talk to realize what a STEMI looks like and walks like. Because if it looks like a duck and walks like a duck, it's a duck. But tonight is not all ducks. Before we go on, there's something I need to get off my chest. If you Google search Levine sign, apart from seeing some good-looking singer in a 90s band, you will see some overweight middle-aged man crushing his chest. If you Google search Levine sign in a woman, you will see some well-dressed woman with their arms crossed in a wonderful butterfly pose, so serene and tranquil. It's ridiculous. We can't even find a woman with a Levine sign. And I think before we meet into STEMI-ish, we need to realize probably what I would say is an extremely important study, which is called the Virgo study. And the Virgo study is a variation in recovery and the role of gender and outcome of 2,000 women and 1,000 young men with MIs at 103 hospitals just like yours. And they looked at MIs and they tried to figure out, are men and women different? And what they found is that 96% of women and 97% of men with chest pain have MIs. It's rather not the people who have MIs, they have chest pain. Women and men both present with chest pain with their MIs. But are they different? We've all been teaching that they're different. What they found is when they looked at women, women are much more likely to describe 3 or more symptoms. So they're more descriptive. They may describe palpitations or epigastric pain. They have more to say. Women will chalk up their symptoms to anxiety, about 1 in 5%, but men, the inferior gender, will only say it about 10%. Men will attribute their chest pain to MSK cases, maybe because they were benching at the gym about 1/5 of the time versus women 15%. But the scary parts are women sought care for a similar presentation about 30% of the time prior to their MI. And over half of the time, women had convinced the doctor that it was non-cardiac. Rather, the doctor had convinced themselves it was non-cardiac. We have been doing a disservice to women. Young women have a higher risk of dying from an MI than men. We need to change. And to start tonight, you need to realize that men and women are typical for their gender. It behooves you to learn this difference so that you can provide better care. So that's off my chest. I want to move forward. I want to move forward and start with the stupidest marketing plot. Who here is the marketing manager for McDonald's? You think that after eating hamburgers, you start getting P waves, maybe a run of heart block, and then non-sustained VTAC. That is certainly not going to get you eating Big Macs. Someone needs a new job. But let's talk patience. Let's talk STEMI-ish. Let me tell you a story. I like stories. This is a 73-year-old female, heart rate 125, blood pressure 177 over 94, and a SAT of 68%. Her story is that she had a recent diagnosis of pancreatic cancer. She woke up today and all of a sudden she felt very short of breath. She didn't have chest pain. She felt short of breath. She came into the hospital. Her chest x-ray looked pretty good, and her story was just hypoxia, but there was no heart failure. There wasn't really much there. When I looked at her ECG, things screamed at me. I even circled AVR. I was pretty worried about her. And now, for time number 2, I'm going to count to 3, and I'm going to ask you what you think her diagnosis is. So put down your drinks, your food. On the count of 3, scream out the diagnosis. 1, 2, 3. Mixed bag. Some people thought STEMI, left main, triple vessel. I want to tell you a little bit about what this woman had. This woman had a massive PE. She had the most thrombophilic malignancy in pancreatic cancer, and she came in hypoxic without heart failure. Her story screamed of PE. What about her ECG? So the first study I want to tell you is about a prospective study of 6,000 patients presented to the ED, 354 with confirmed PE. And look at those high likelihood ratios. 8.5% had an S1Q3T3, 10.5% had precordial T-wave inversion, almost 30% were tachycardia. But look at how high those likelihood ratios. And we're going to circle back to this woman's care afterwards. When we have a meta-analysis of 10 studies of 3,000 patients with PEs. When you look at the ECG, it is more than just showing off to your residents to say, what does Rosen's or Tintinelli tell you about PEs? Look at the odds ratios. If you have T-wave inversions in the precordial leads, if you have ST elevation in AVR, if you are tachycardic, if you have a right bundle, these are not just things to rhyme off, but they are highly predictive for cardiogenic shock or death. You need to respect the ECG because the EKG predicts clot burden and seriousness of illness. Now, we talked about AVR and I circled AVR, and some of you probably fell for the AVR trap. And the AVR trap really came about 5-6 years ago when people really started to fuss out about ST elevations in AVR. And this was presented at conferences by multiple EKG gurus. And we started activating the cath lab, much to the chagrin of our cardiologists. When they looked at 100 patients with ST elevation in AVR, and they looked back, a third of them had an ACS, a third of them had tachyarrhythmias like hyperkalemia, and a third were non-cardiac causes like PE. And only in 10% of these acute ST elevations in AVR was there a culprit lesson found. What you have to realize is this is very much akin to the old days when we used to call the cath lab for left bundle. You would see these new left bundle and they would be eating a bag of cheesies and laughing and on their devices, and you just knew that wasn't a STEMI. You need to take a little bit of a story. You need to realize that just the EKG is one piece of the puzzle. And the area where I think the real mimic takes care is when PEs decide to screw you up and pretend to be LAD ischemia. This is a great study of 100 PEs and 250 cases of ACS caused by LAD ischemia. But look at these ratios. If you look at the group with these cohorts, 22% had the S1Q3T3, none of it in the ACS group. 6% had right axis deviation, none of it in the ACS group. And the T-wave inversion was very specific for PE. You have to realize this, and let's circle back to our patient with the hypoxia and cancer. She has all these classic findings. Yes, we have circled her ST elevation in AVR, but you also see the S1Q3T3. You also see right axis deviation, and you also see T-wave inversion in lead 3, as well as in the precordial leads. Here's another great example. I saw this woman, she's 85. She came back from Hong Kong and she got off the plane and about 6 hours later was profoundly hypoxic. Her story does not scream ACS. Yes, she has ST elevation. And yes, the astute clinician's going to say, whoa, there's some T-wave inversion precordially. I wonder if she's a Wellens. But let's circle here. Let's look here. She has S1Q3T3. She has T-wave inversion in lead 3. And she also has the T-wave inversion in all of her precordial leads. When you see someone who has precordial inversion and you're thinking Wellens, what I want you to do is turn your head to the left and look at lead 3. Think of it as a Wellens +1. If you have a Wellens sign with T-wave inversion in lead 3, you must think PE. But you have to take a story. A story is everything. I mean, sometimes ECGs lead you the wrong way. This is a 32-year-old with a cough and a fever and a bad man cold prior to the advent of COVID. He had end-stage manthrax. I got his ECG, and this is old. You know how I know this is old? Because I still knew how to write in cursive. And back then, I was right. There was ST elevation in lead 1 and AVL. But you know what there wasn't? There was no story. Story is everything. History is queen. Learn to take a cardiac story. It is everything. Don't treat EKGs, treat patients. One of the most important things that I want to tell you about today is this concept called MINOCA. And MINOCA is an MI with non-obstructive coronary arteries. It used to be called MINC, but the spelling was kind of screwed up. And what we know about MINOCA is it's about 5 to 15% of MIs, 5 times more common in female. And essentially, it's someone who has an acute MI, but the cath shows no significant stenosis and no overt cause. And the current definition of MINOCA excludes a thing like the myocarditis we just saw. It excludes Takasubos. It excludes a dissection that presents with an inferior MI. It has unique examples. And the next example, to me, was a game changer. And I want to tell you another story. This is a story about a 33-year-old female who comes in with crushing chest pain that's radiating down her arm. She is diaphoretic. And again, diaphoresis is not something that you ask. You can see. She's sweating profusely. She looks like a STEMI, but she's 33. She's also 36 hours postpartum from her 5th child. And I saw this with Dr. Richard Lee, who's out in BC. And if he's listening, Richard, this was a case that changed both of our careers. I want to show you her ECGs. Now, I'm pretty good at chest pain in patients who are pregnant. I mean, up before this talk, really, if you were chest pain and you were pregnant or postpartum, I knew I had a really good differential, which was you had a PE. But we've already talked about PE. And you know what? She doesn't have that S1Q3T3. She doesn't have the T-wave inversion. She doesn't have AVR. So I'm starting to get nervous. I know that PE, and I know that pregnant women also can have dissections, but dissections typically pick off the right coronary and they present with an inferior STEMI. So I'm starting to say, why does a 33-year-old healthy woman have a STEMI? I'm pretty scared. I'm pretty nervous. So this is the final time I'm going to count on you. I'm going to count to 3, put down your drinks, put down your food, and on the count of 3, tell me what you think she has. 1, 2, 3. Ha, I heard it once from the person in Manitoba who's getting ready for CAEP 2021. This young woman had SCAD. Now, if you Google search SCAD, you will find ads for the Savannah College of Art and Design. SCAD is a spontaneous coronary artery dissection. It is not a traumatic one or iatrogenic. It is spontaneous. And if you haven't seen SCAD, you've missed it, or you didn't follow up on your angios. When you think about SCAD, SCAD represents and presents with 30% of the time as a STEMI and 70% as a non-STEMI. It apparently represents up to 4% of all angiograms that go to a cath lab for ACS. And 32 to 46% of the time, it affects the LAD. Just like an aortic dissection, it results from an intimal tear. And you have the same symptoms as an MI. And what you should know about SCAD is they present exactly like an MI. They're impossible to distinguish clinically. Even the master clinician can't, except some features. You don't see troponin negative SCAD for the most part. It just looks like a STEMI. So what's the big deal then? You need to know who the usual suspects are. What you need to realize is that this is responsible to 20 to 43% of MIs in young women less than 50. And it is a young woman's problem, with 85 to 94% of the incidents occurring in women. The mean age is 43 and over 90% are less than 65. These young, fit women are the poster women for SCAD. Now, there are two types of SCAD. There is a pregnancy associated SCAD, and essentially the coronary arteries have estrogen and progesterone receptors on them that weaken throughout the term and weaken with multiple gestation. It's the reason why it's more common in the third trimester, it's more common in grand multips, and it's common up 3/4 of the time it occurs postpartum, like in our woman. It represents 8% of all SCAD. And unlike non-pregnancy associated SCAD, they do worse. They're much more likely to have STEMIs than NSTEMIs. They have LAD involvement, they have ventricular failure, and they tend to have longer segments dissected. This is a very bad problem. And hormones seem to play a role in SCAD about 10 to 13% of the time. And this can occur when you start the OCP. This can occur, obviously, we talked about pregnancy and postpartum, but also one postpartum state where you don't really think about postpartum is it can also occur when a woman stops breastfeeding. So she may be a year or a year and a half or 6 months postpartum, stop breastfeeding and get this symptom. And that's a key hormonal surge. The other one is, and I have to be careful, my wife always says when I talk about this, is menstrual angina. That sounds horrible. This menstruation isn't bad enough. When you see those progesterone surges, imagine every month having an anginal equivalent because of hormone fluctuations. SCAD patients get this. They just always aren't diagnosed. The other important thing to realize about SCAD is 60% will have a significant stressor. 40% will be an emotional stressor. Your partner left you, you got fired from a job, you lost a loved one, and 20% will be a physical stressor, like you completed a try, or you did some isometric exercises at the gym. But in a young female or young person who says, you know what, I had chest pain, but I just had a fight with my partner, these are the people we blow off. So you have to be careful and not be colored and mislabeled by the fact that there's an emotional trigger, because the emotional trigger is the problem. If any of you have ever heard me talk, I am a simple person and I think about patterns. With SCAD, there are 3 key patterns. And I like to think about it when you have ACS plus 1. 1, you have ACS plus a young female with no risk factors. Think SCAD. 2, you have ACS plus a woman who is postpartum or pregnant. Think SCAD. Or finally, you have ACS in a person, likely a woman, with significant emotional or physical stressors. Think SCAD. And why am I telling you this? Why is it important to think SCAD? Because you need to plant that seed to the cardiologist, because this is not typical ACS. And depending on where you work, things might be completely different. We have listeners across the globe. We have listeners across the country. I work in an ivory tower with a cath lab, but all of us don't. And it is not standard ACS therapy. Much like an aortic dissection, you don't want to give TPA to patients with a spontaneous coronary artery dissection. And hey, you probably don't want to give them a heparin or Fonda or enoxaparin either. What you need to do is pick up the phone and plant the seed and speak to your cardiologist and say, listen, I have a 38-year-old female with no risk factors who doesn't use cocaine, who has come in with what looks like a STEMI or non-STEMI. I'm really worried about SCAD. Can we get her to the cath lab? Because that will guide your diagnosis and therapy. Now, I'm not going to go over this other than ideally in the first type, which is pathognomonic coronary wise, you see a double lumen, you see that false lumen. The other types are more difficult. But if you plant that seed in the head of the cardiologist, she might think, Merch Doc was worried about SCAD. These coronary arteries look clean. There's not too much atherosclerosis. I don't see evidence of plaque rupture. I wonder if he's onto something or she's onto something. Maybe they have SCAD. And so this is an angiographic diagnosis. But your history taking is so important because the therapies can harm if you treat the wrong person. What you have to realize about SCAD, unlike plaque rupture, is an overwhelming majority of 70 to 90% heal spontaneous. But this is not the cath that people want to do. There's a technical failure, depending if you're looking at Canadian, American, and European data, between 27 and 53%. And there's a 15 times increased risk of a iatrogenic dissection. These are long segments, and typically they can be mid to distal, and you need really long stents, and they don't do well. And typically these patients will have complications, and patients with SCAD will need to be kept in hospital longer because they can re-tear or have problems delayed. It's not like you get your cath and you go home a day or two later. You're kept and you're monitored. And unlike ischemia, that when you fix it, the pain disappears. When you have SCAD and you've ripped an artery, it doesn't disappear. You continue to have pain. It eventually heals, but it's really hard to figure that out if you're not doing repeated angios. And cabbage isn't your friend. About 13% of really significant SCAD who get PCI'd will go on to have cabbage. The problem is, unlike the cabbage where you have the cabbage and you got a new set of vessels for 20 years, these vessels will tear as well. It doesn't give you that lifelong protection that a cabbage does. You really don't want to go there if you don't have to. And I think the key is, and you'll see this angiographically, and the problem is we don't get the follow-up because we don't look up our patients. When you see a 35 or 40-year-old or 45 or 50-year-old female who goes to the cath lab, read her cath report because sometimes they're SCAD. You just didn't know about it. And typically they will shoot angiograms. When they're coming down, they'll look for this string of bead signs, which is something you see in fibromuscular dysplasia. And fibromuscular dysplasia is a non-atherosclerotic, non-ischemic thickness or hypertrophy of a vessel. And we don't know, and we're still learning because SCAD is relatively new, whether that SCAD is just a coronary equivalent of FMD. And that's all that it is. But when you shoot angios, and after these people, they get CTAs from brain to pelvis because about 10% of them will have a brain aneurysm. And there's also an association with migraines. So typically these people will get CTA, brains, chest, abdo, pelvis, looking for other aneurysms and other vessel abnormalities. There is an association. We talked about hormones, pregnancy, connective tissues, the old bad stuff like Marfan's and Ehlers-Danlos, they're all there. But fibromuscular dysplasia seems to be the big one. SCAD's no fun. 20 to 29% of people will have a recurrence. Mortality is not bad, but the mean recurrence is 2.8 years. This is something you live with. And if someone has a history of SCAD and they come to see you, you better have SCAD on your radar again. So what can I tell you before I let Jesse take over? I think you have to realize that men and women are typical. You just need to realize what typical is. You have to realize that there are biomarkers or there are ECGs, but history is queen. History is everything. Take an excellent history. You will make diagnoses. You need to know the significant findings that electrocardiographically show a PE. And you have to know the ones that predict bad outcomes. And the bad outcome you need to think about is Wellens +1. When you see Wellens, you have that ST elevation in AVR and you're going down an LAD route, you're going down a cath lab activation, and you see that precordial T-wave inversion, and you think you're smart, turn to the left and look at lead 3. Because if you see T-wave inversion in lead 3 with a Wellens, you have a PE. And think about SCAD in young women. Think about ACS +1, ACS plus young woman with no risk factors, ACS plus postpartum or pregnant woman, or ACS plus a significant emotional or physical stressor. And then you will save lives. So with that, I am going to stop sharing. I'm going to let my colleague, Dr. McLaren, let Jess take over. Jess is going to share his slides. And then after Jess is done, I'm going to come off. Jess is going to go on. We're going to have about 10 minutes for questions when I'm done.
All right, so it is difficult to follow Dave Carr and to live up to his generous introduction, but I will do my best. The objectives of these CAEP National Grand Rounds is to apply up-to-date evidence to inform clinical decisions and to influence the future direction of emergency medicine. And with this in mind, I want to talk about occlusion MI and do so through the prism of quality improvement, which is how I became interested in it. Now, the diagnosis of acute coronary occlusion has been simplified and standardized into STEMI criteria and then automated by computer interpretation. According to this paradigm, ST elevation reflects acute coronary occlusion, and if you don't have ST elevation, you do not have an acutely occluded artery. Now, standardization and automation are really high up there on the hierarchy of effectiveness. But what if the paradigm they're reinforcing is flawed? Dave talked about one side of this, which is false positive STEMIs, those that meet STEMI criteria, but that don't have an acute coronary occlusion, and where history is important. I want to talk about false negative STEMIs, those that do not meet STEMI criteria, but that do have an acutely occluded coronary artery, and where advances in ECG interpretation can make a difference. So we're going to start. I also want to make this interactive, so grab a pen. We're going to write down the 5 criteria for acute STEMI. You have to have ST elevation, it's in the word. It has to be at least 1 millimeter and greater in V2 and V3. It has to be in at least 2 contiguous leads. It has to be, you shouldn't have like Q waves because these are evidence, as it's thought, of either old or completed MIs. And STEMI is defined as ST elevation in the absence of left bundle branch block. So with this in mind, I'm going to go through 5 cases and write down the answers, yes or no, to 2 different questions. 1, is this a STEMI? And 2, does the patient have an acute coronary occlusion? The first patient is a 55-year-old male presenting with 2 hours of crushing chest pain and diaphoresis. There's mild anterior ST elevation, but it's less than the 2 millimeter threshold. Case 2 is a 40-year-old male with 2 hours of chest pain and shortness of breath. There's ST elevation greater than 1 millimeter, but in 1 lead only. The third is an 80-year-old female with 3 hours of chest pressure and nausea. There's no ST elevation anywhere. The fourth is a 75-year-old male with 2 hours of chest pain, shortness of breath, and lightheadedness. There's some mild anterior ST elevation, but there's also Q waves, so it could be old. And the fifth is a 60-year-old female with 4 hours of chest pain and a left bundle branch block. Now, if we think back to our criteria, none of these patients met criteria. So the answer to the first question would be no, these patients don't have STEMI. But all of these patients have an acutely occluded artery. So the answer to the second question is yes, these patients do have an acute coronary occlusion. So we've now gone through the first step of quality improvement, which is identifying a problem. Now we're going to go through a root cause analysis of this problem. And I want to talk about 5 articles of the past 5 years that will hopefully change the way you see STEMI. First is the prospective validation of STEMI criteria, published in the International Journal of Cardiology in 2019, looking at 2,500 patients with chest pain presenting to the ED. Only 35% of them had STEMI criteria measured by computers on their first ECG. Now, one of the reasons was technological, in that the computers just didn't measure correctly, and this is why you should never trust interpretation. Another reason was because the pathology, acute coronary occlusions are dynamic events, and ST segment can fluctuate, which is why we get serial ECGs, we all know that. But the 2 other reasons were either they had minimal ST elevation with reciprocal change, or they had anterior ST depression from a posterior MI. And both of these actually speak to the limits of STEMI criteria. As the authors concluded, clinicians have to be aware of this major limitation and address it through a holistic interpretation of the ECG. Second article is a meta-analysis of 40,000 patients with a discharge diagnosis of STEMI, published in the European Heart Journal in 2017. And that's right, 1 in 4 STEMIs have a totally occluded artery. Because they don't fit into the STEMI paradigm, they have delayed reperfusion and higher mortality rates. And the authors of this study concluded that we need to have better tools to identify these high-risk patients. Now, it turns out in the search for these better tools, there's actually been not only better tools, but a better paradigm that's emerged. And if you haven't read it already, read the 2018 OMI Manifesto. This is written by emerged physicians, Stephen Smith and Pendle Myers. They take a deep dive into the whole history of the STEMI paradigm, and they come to a very important conclusion. They say the term STEMI cognitively inspires us to think that only the ST segments matter, that the ST segments are reliable and don't depend on the preceding QRS complex, and the ST elevation is the only necessary data point for making the reperfusion decision. Is the patient having a STEMI must be replaced with the real question we need to know. Does the patient have an acute coronary occlusion that would benefit from immediate intervention? To accomplish this, they go on, we propose the term OMI as an alternative, occlusion MI. Fourth is their comparison of these two paradigms. This is hot off the press from the Journal of Emergency Medicine. Of patients with an occlusion MI based on angiography and P troponins, only 60% fit into the STEMI criteria. These, of course, had rapid reperfusion, but that means that 40% of occlusion MIs did not fit into the STEMI paradigm. And as a consequence, they had delayed reperfusion and they had infarct sizes actually similar to the STEMI positive occlusion MIs. Most important question is, can we identify these? And again, the answer is yes. This is a difficult trial, the diagnostic accuracy of ECGs for acute coronary occlusion resulting in MI. And of 1,000 patients with STEMI, 28% could be reclassified as acute coronary occlusion based on advanced ECG interpretation. So we've gone over the root cause, we've identified some limits to the STEMI criteria and some opportunities for improvement. What's interesting is that some of these limits were actually recognized at the dawn of the STEMI era 25 years ago. So this is what Annals of Emergency Medicine had to say in 1994 about STEMI. They said ECG abnormalities may be subtle or open to different interpretations, like early repolarization or pericarditis. Only borderline or minimal ST elevation may be present, and it may be uncertain of its significance. Left bundle branch may complicate the diagnosis, or we may suspect that the ST elevation is old. Now, of course, at the time, they couldn't do anything about the limitations besides highlight them. And at the time, STEMI was the best thing going. But 25 years later, we actually have the tools not only to identify these limitations, but to overcome them. So now I want to look at 5 evidence-based tools to identify occlusion MI. Now, Dave has helped to popularize the whole concept and the approach of the +1. These different talks on dissection. We've just heard now about Wellens +1, about ACS +1. This +1 concept is actually very helpful as well for occlusion MI. So let's say you see a patient with borderline anterior ST elevation, and you don't know which path to go down. Is it an LAD occlusion that will lead to rapid myocardial destruction, or is it simply a healthy, normal variant? Again, we have to look at the ECG holistically. And so there's this rule that differentiates LAD occlusion from early repolarization, and it starts with exclusion criteria. So if your anterior ST elevation is accompanied by Q waves, by terminal QRS distortion, that is the lack of an S or a J wave in those leads, by greater than 5 millimeters of ST elevation, non-concave ST elevation, anterior ST depression, T wave inversion, or inferior reciprocal change, then it's not normal. If it doesn't have any of those, and there's still a concern, there is a calculation available on MD-Calc that puts the degree of ST elevation in the context of a QRS complex, especially the R wave. So we come back to our first patient. They were STEMI negative. They only had borderline minimal anterior ST elevation, which is why the computer called it early repolarization. But they have the beginnings of anterior Q waves. They have terminal QRS distortion in V2. And they have these giant hyperacute T waves that could swallow the entire QRS complex. This was an LAD occlusion. Similarly, this 30-year-old was assumed to have early repol because they only had borderline, concave, happy face, ST elevation, and there's no reciprocal changes. But look at those Q waves. They've totally lost their anterior R waves. This is not normal. What's more is they have a hyperacute T wave in V3. This, in the context of this patient's 5 hours of chest pain, was LAD occlusion. This patient, on the other hand, was brought in as a possible code STEMI because they had ST elevation anteriorly. But check out the size of those R waves. They're literally off the page. This is a relatively small ST elevation. Other than a sliver of a Q wave in V2, there's no other concerning features. So rather than activating the cath lab, this patient had serial ECGs, serial troponins, and a reassuring bedside ultrasound, and were ruled out for MI. So when you see borderline ST elevation, you're not sure which path to go down, think of the +1. There is a rule for LAD occlusion, which starts with looking at the ECG holistically. The second +1 is with inferior ST elevation. Now we know that STEMI criteria is not sensitive for identifying inferior occlusion MI, but we also know that there's other etiologies like pericarditis that can produce mild inferior and infralateral ST elevation. So how do we tell them apart? So again, a study that was published in the American Journal of Emergency Medicine in 2015 saw that of those with inferior occlusion MI, many didn't meet STEMI criteria, but 99% had some degree of ST depression in AVL, and 0 cases of pericarditis had that as well. So ST depression in AVL is highly sensitive for inferior MI and highly specific because it excludes pericarditis. You just have to be aware that you can also have ST depression in AVL secondary to abnormal depolarization, whether it's left bundle, LVH, WPW, or of course from an old MI. So again, you have to look at the whole ECG and look at the patient. So our 40-year-old, previously well, no history of MI, no left bundle, no LVH, comes in with acute chest pain. The ECG is interpreted as nonspecific because it does not meet STEMI criteria. But the fact that they have significant ST depression and T wave inversions in AVL, in addition to lead 1 for that matter, actually makes this highly specific for an inferior occlusion MI. Similarly, this patient, a 45-year-old previously well, was in the waiting room and had his ECG done. It was brought into the emerge physician. There's only ST elevation in 1 lead. This is STEMI negative. But the emerge physician was very concerned about AVL. So she brought in the patient, did a quick ultrasound, saw the inferior wall was down, activated the cath lab, and they had rapid reperfusion. This patient, on the other hand, does meet STEMI criteria. They have ST elevation greater than a millimeter in all 3 inferior leads. And so the computer applies the label STEMI. But look at AVL, totally normal. Now, you have to be very careful before applying the diagnosis of pericarditis, but this patient's pain was certainly not typical for ACS. Rather than having the cath lab activated, they had serial ECGs that had no change from this. They had serial troponins, they had a normal bedside ultrasound, and they ruled out for MI. So if there's borderline inferior ST elevation, have a look at the +1 in AVL. Third is posterior MI and the importance of inverted mirror image. So as you know, posterior ST elevation produces anterior ST depression. Posterior Q waves produce anterior R waves. And we've been told because of the focus on ST elevation that you have to have significant posterior ST elevation to diagnose a posterior MI. That's not actually what the studies show. So there was a study that occluded, that looked at circumflex occlusions causing posterior MI. Of those that achieved 1 millimeter of posterior ST elevation, that was only half of them, of the posterior MIs achieved that amount. And of those, 98% already had anterior ST depression. So the posterior leads added nothing. Where they were helpful was that a quarter of posterior MIs only had half a millimeter of posterior ST elevation without significant anterior depression. So it's these subtle posterior MIs where the 15 lead can be helpful. Let's go through some examples. Our 80-year-old, no history of MI with acute and ongoing ischemic symptoms, has tall R waves in V2 and a significant amount of ST depression, which is isolated to these anterior leads. This is diagnostic of a posterior occlusion MI. The fact that their posterior leads are so tiny with such minimal elevation actually led to a delayed diagnosis of their circumflex occlusion. Similarly, this 40-year-old previously healthy with acute chest pain had significant anterior ST depression. Now, posterior MIs can involve the inferior wall as well, and so you can glance over and see very subtle convex ST segments with a little bit of reciprocal change in AVL. So this was infraposterior MI caused by an occluded artery. Unfortunately, their 15 lead was falsely normal, so they were admitted as a so-called non-STEMI, and 18 hours later had a stent put in the circumflex. This patient, on the other hand, shows a real value of the 15 lead. They only had subtle ST depression anteriorly, or what we call pseudo-normalization. But if you look at the 15 lead, it's much more obvious that they have elevation. So in this situation, the posterior leads were very helpful in identifying and treating the circumflex occlusion. So ST depression in V2 and V3 is a mirror image of posterior ST elevation. And you just have to be aware when the 15 leads can help and when they can hinder. The fourth +1 involves anterior Q waves and ST elevation. So if you have an old MI with an old LV aneurysm, this can give persisting ST elevation that can be mistaken for a new MI. Or if you have a brand new acute occlusion, this can produce Q waves in as little as an hour that can be mistaken for an old MI. Or you can have an old MI with a new MI. So how do you tell these pairs apart? Here, the +1 is the T over QRS ratio. In other words, is there a hyperacute T wave after that Q wave? If there is a hyperacute T wave, which is defined as greater than 0.36 or around a third of the QRS complex, then it signifies an acute coronary occlusion. If it's less than that ratio, then it's either subacute or it's old. So as an example, remember a patient who had Q waves and some mild ST elevation anteriorly. The computer called it septal infarct, age undetermined. But we know the age. Look at that hyperacute T wave in V3. It's 3 times the QRS complex. This is huge. And indeed, this was an acute LAD occlusion causing acute Q waves and hyperacute T waves. We can also see some De Winter waves in V4 and some inferior ST depression. This was a proximal acute LAD occlusion. Similarly, this patient came in with anterior Q waves of, not sure if it was, actually, sorry, they had no previous MI, just 40, previously healthy, 7 hours of chest pain, Q waves. And look at the height of the T wave in V3. It's greater than a third of the QRS complex. So this is acute. This patient, on the other hand, had a prior MI, came in with just a few hours of symptoms, had these Q waves with mild ST elevation, which was the same size of ST elevation as the previous patient. But if you look at their T waves, they're really, really small compared to the QRS complex. Plus there's some T wave inversions. So this was just their resting LV aneurysm pattern, and they had an unnecessary trip to the cath lab. So when you see anterior Q waves with ST elevation, your +1 is going to be to look at the T over QRS ratio. And finally, left bundle branch block. How do we see through the chaos of abnormal conduction and spot the MI? Now, it used to be that left bundle itself was considered a criteria to lyse. Then it was removed completely, and now STEMI is defined as the absence of left bundle branch block. But Elena Scarboza developed her own +1 rule, including concordant ST elevation, concordant ST depression in the anterior leads, and disproportionate ST elevation. Now, at the time, she defined that as a 5 millimeter cutoff, but this doesn't take into account different sizes of complexes. As we said, you have to put the ST segment elevation in the context of the QRS. And that's what Steve Smith did with the modification that looks at ST elevation greater than 25% of the preceding S wave. So this patient, by STEMI criteria, simply has a left bundle branch block, which is what the computer says. By Scarboza, they have concordant lateral ST elevation. And by the Smith modified rule, they also have anterior elevation. While their ST segment elevation is less than 5 millimeters, it's greater than 25% of the preceding S wave. So this is an anterolateral acute infarct caused by a proximal LAD occlusion. Another example of Scarboza's criteria is this patient who came in with concordant ST depression in V3, which was from a circumflex occlusion that was unfortunately missed until the patient suffered a VFib arrest. This patient, on the other hand, had the cath lab activated because they had greater than 5 millimeters of anterior ST elevation. But if you look, their complexes are huge. The degree of ST elevation is actually quite small. It's way less than 25%. This was actually their baseline ECG. There was no signs of occlusion MI on the ECG, but remember the question, is the patient having an acute coronary occlusion? And this is a 50-year-old with refractory chest pain and a positive trope that mandates the cath lab. And indeed, they had a circumflex occlusion, which is often not seen on any ECG, even with normal conduction. So when you see left bundle branch block and you're concerned about an occluded artery, look at the modified Scarbosa's criteria and always put it in context of the patient. So we start with a problem. Does this patient have an occlusion? We then saw that the STEMI criteria often doesn't help to answer that. We looked at some opportunities for improvement that have come about from ECG advances. The next question, the more challenging question, is how do we implement and monitor these? How do we learn and apply the new paradigm? And I'm not suggesting this can be done tomorrow. First of all, ECG interpretation is a skill which takes time. And secondly, we're not the only ones involved in the reperfusion decision. The occlusion MI paradigm is not the present of emergency medicine, but it is the future. The question is, what steps can we take to head towards that much brighter future? The first thing we can do is simply to learn these advances. We can also learn from our patients. As Dave said, you should be following up on your cath lab reports. You can see which were false positive STEMIs, which were false negatives, which had delayed reperfusion, which had rapid reperfusion, which signs of occlusion MI were detected and which were missed. You can do this as an individual, and you can also do this as a department. So I'm just going to share our own experience. We looked at 3 years of code STEMIs from the eMERGE with culprit lesions. We saw that those that met classic STEMI criteria were often identified by the machine as well as a provider, and as a result, they had a very short ECG to activation time. But 25% of them had a prolonged ECG to activation time, not because there weren't signs of acute coronary occlusion, but because it wasn't detected. And this included STEMI equivalents like Scarbosa's or posterior MI, or rules for subtle occlusion like subtle LAD occlusion or subtle inferior MI. In other words, a quarter of our code STEMIs that we activate from the eMERGE have delays to perfusion despite their very first ECG having diagnostic signs of acute coronary occlusion. The next step is, what can we do to try and integrate these new insights and apply them without, of course, going overboard and activating the cath lab on every patient. And this is where I think these rules help to apply as well, both to avoid false positive and false negatives. And again, just to share our own experience, this is a quality improvement project that started with a Grand Rounds presentation, just like this. And then for the next year, we shared on a weekly basis ECGs from all of our challenging code STEMIs to every group, every provider in our group. This included false positive STEMIs, false negatives, and literature on occlusion MI. And through the process, we reduced the ECG to activation time for code STEMIs with culprit lesions without increasing the percentage of code STEMIs without culprit lesions, which was our balancing measure. So to conclude, we have to start with the right question. Does the patient have an acute coronary occlusion? And know that STEMI criteria will often not provide you with the right answer. There's lots of opportunities that we can use to learn from this up-to-date evidence. So if there's a borderline ST elevation, there's a rule for subtle LAD occlusion. If there's inferior ST elevation, you can look at ST depression AVL. If there's anterior ST depression, consider posterior MI. If there's anterior Q waves with ST elevation, look at the T to QRS ratio. If there's left bundle branch block with ischemic symptoms, look for modified Scarbosa criteria. We can learn the literature, we can learn from our patients, from our cases, from our department, from each other, and then consider how we might start applying these in daily practice and as a group. And through the process, I think we can move away from an older STEMI paradigm, which started with millimeters on a page and produced false dichotomies, and towards an OMI paradigm, which starts with occluded arteries and reveals new ECG insights. I'll just end with a couple of resources. If you only have time to read one article, let it be this one, New Insights into the Use of the 12-lead ECG for Diagnosing AMI in ED. This is a collaborative article. It was co-written by both cardiologists and emergency physicians. It was published in the Canadian Journal of Cardiology. You can follow Dr. Smith's ECG blog, which is really leading this paradigm shift. And if you want, I won't mind if you check out my own blog. It's a monthly review of ECG advances with a focus on MI. Check it out. Let me know what you think. Thanks a lot for tuning in.
Jess, that is a nerve-wracking proposition that a quarter of STEMIs have totally occluded arteries. I mean, I've been judging on a lot of Gestalt for a long time and relying on history, but those were some incredible pearls that I think has definitely opened my eyes. I've certainly made notes because I'm going to be more fearful the next time I see an ECG.
So we had a question come in, and maybe I'll pose it to you, Dave. So you talked about a number of etiologies in terms of SCAD and myocarditis. Another one, which I think you mentioned, was Takotsubo's. And so this was a question from a rural doc who's 5 hours away from a cath lab. And the question is, can we differentiate Takotsubo's from STEMIs?
No. I mean, you're 5 hours away. This is something that you have to use your, your critical care resources, your get critical on the phone, speak to a cardiologist, fact ECGs, tell the story. Maybe there's some Takotsubo's response, some sympathetic drive. Maybe it's SCAD. You won't be able to tell. But that's why angiograms and echoes are very helpful. And in those cases, just like in the case of SCAD, I think the real challenge is these are shared decision-making between you and the interventionalist. And it's a risk benefit. Like if you're 5 hours away from a cath lab, you may need to think about antithrombotics, TPA, but that's going to be a discussion. What your job is to identify these variants, these MINOCAs, things like Takotsubo's and Kunis syndrome, which we didn't talk about, and SCAD and weird stuff, that plant that seed, have that discussion, because it's not standard therapies. And Jess, you look really studious with all those books back there. I feel like such an idiot with my wall of like basketballs and stuff like that. You're much more learned. I mean,
this is just to hide all my Archie comics. I have to pretend like that this is actually based on something.
Okay. I'm happy. We're both happy to take any more questions. Please feel free to bug us. If not, we're going to start asking questions of each other, and that will be much more boring. But please, if you have anything, spit it out. We're at about 7:58, so we have you for about 3 more minutes. Jess, what would you say? You present, I loved your plus ones and I loved what you thought. What has been the biggest change for you in terms of, you presented 5 key things. Is there one that you can say is better than the others? Like, is there one that is bigger bang for the buck? Are they all equal in terms of, the Scarbosa stuff we kind of heard about? Do you have a favorite one? I know that sounds silly.
How nerdy am I?
Well, I know.
Yeah, I love the AVL because inferior MIs are common. Obviously, it's going to be much more common to use that than to use the LV aneurysm, rule potentially. So the changes in the AVL I think are super helpful. There's a question around the test characteristics. I don't have it off the top of my head, but again, if you look at that article by Miranda et al., they will give you the references, the test characteristics, all of this for LV aneurysm. So it is right in there. The other question is there a definition of hyperacute waves in the absence of LV aneurysm? And the answer is no, which again, I think shows you we're 25 years into a paradigm on ST elevation, and we can't even define what is hyperacute. Not to say that it's not important, it's hugely important, but I think that really shows that there's so much more to learn. And I feel more and more ignorant the more I learn about this, but there's so much more to learn.
Jess, It took me so long to get over the angina and unstable angina thing. So now you're going to get me in the non-STEMI and STEMI and try to change things. One of the other questions I see that came in about antiplatelet agents in SCAD. Look, the reality is typically people who have SCAD are started on aspirin. That doesn't seem to be a major problem. If they get a stent, they typically get dual antiplatelet therapy. If they don't get a stent, they typically are maintained on aspirin. So I wouldn't be worried about aspirin. I would maybe not start dual antiplatelet if I thought it was SCAD, but I think aspirin, which is often given pre-hospital, is not a major problem. I think the big ones are TPA for sure, and then your antithrombotics, your heparin, which you may want to just discuss. Often these are discontinued at the cath lab time. So that's kind of where things are at, as opposed to we used to like to start things upstream. Now it might be started downstream. Jess, question for you, which is, when I call CCU, they want to they look at the ECG, but then they want to come in with echo. And how much of the paradigm is echo related? Because that's not one of the things you talked about, but how much is regional wall motion abnormality an issue?
Yeah, I mean, of course, they definitely complement each other, but I think it's also important to recognize that echo, just like using POCUS in people who are undergoing CPR, can be double-edged. It can help find you things, but it takes time. And so we're actually going through a quality improvement project with a cardiologist because we realize that after we call code STEMI, patients don't leave for 20 minutes because echoes are being done, which just delays care. And we've had a lot of cases which are actually quite diagnostic on the ECG, which don't need echo. On the other hand, like that 40-year-old in the waiting room I talked about, very subtle ECG, echo was super helpful. So I think we just have to be aware of the strengths and limitations of all of the modalities.
Yeah, and I think there's so many POCUS gurus amongst us that it's amazing the way wall motion abnormalities is now becoming an emergency department skill for a lot of sonographers who have expertise. So I think the envelope's being pushed. Now, I'll kind of wait another minute before any other questions. What I will say is both Jess and I would love if there are evaluations. Your CME is not contingent upon the evaluations. You're getting your certificate, but it's really helpful to us and to CAEP so we can improve and get better for the next time we do this. So please fill out your evals that you get from Gail and from the folks at CAEP. And last chance, anyone have any final questions before Jess goes back to read all those books? I think he's on the third shelf now.
Somebody had asked for a link, which I did put in the chat, but in case people don't have the chat, again, that reference article is Canadian Journal of Cardiology 2018, New Insights into the Use of the 12-lead electrocardiogram for Diagnosing Acute Myocardial Infarction in the Emergency Department by Miranda et al.
Okay. I think on that note, and that's an amazing article, thank you so much for spending your evening with us. Be safe. Remember, the best way to save lives is to learn and to listen and to remember everything Jesse said. So thanks so much, everyone. Be safe. We're almost done this pandemic, and we'll see you all soon, hopefully at a CAEP nearby.